Hi everyone, welcome. Before we begin, I'd just like to acknowledge the lands in which I'm coming from today, which is the lands of the Gadigal people of the Eora Nation. And I'd like to pay respects to elders both past, present, and emerging. And sovereignty was never ceded. I always was and always will be Aboriginal land. So welcome everyone to the third and final session of our three-part webinar series, The Divergent Epidemic. My name is Justin Salerno, and my pronouns are he, him, and I am the Senior Project Coordinator here at Health Equity Matters. It's great to have you back, and if you're joining for the first time, welcome. Just a brief recap of our second session. We were joined by Jenny, Dewey, and Jade, who shared with us the experience of communities in Greater Sydney who are impacted by HIV and what practical changes each of us can make to support greater equity in Australia's HIV response. Some of the key themes we explored included the urgent need for community-led responses, stronger need for each of us to address the structural drivers of this inequity, key of these being racism. Another important takeaway from our session was that each of us must be a part of the solution, but ultimately we must be led by community to ensure that the response is by community for community. Session 3 explores the critical gaps in HIV and community health data collection, particularly when around culture and ethnicity. Focusing on the implications for the HIV response and STI surveillance, this session highlights why accurate, comprehensive, and timely data matters and offers practical steps to improve how each of us and the services that we work within can work collectively. Being led by community can create more meaningful and representative data systems. Some housekeeping today. A quick reminder that today's session is being recorded and will be available on the Health Equity Matters website after the event. Please feel free to use the chat throughout to connect and share reflections. For any questions to our speakers, use the Q&A feature. And if you'd like to ask your question directly, just let me know in the chat and we'll pass you the mic. We're fortunate to be joined today by a speaker working at the intersection of data, health, equity, and the HIV response. Please join me in welcoming Elena Ruka, researcher at UNSW Kirby Institute. Ella has been working at the Kirby Institute for the last 7 years and is involved in assisting the production of the annual surveillance report on HIV, BBVs, and STIs among Aboriginal and Torres Strait Islander people. She led the production of the CALD Enhanced Surveillance Report last year and the systematic review to analyse the gaps and inconsistencies in the CALD health data collection in Australia, which she will be speaking about in today's webinar. Over to you, Ella.
Thank you so much, Justin, for the beautiful introduction. Hello, everyone. I'm really excited for today's webinar. I will just quickly share my screen so that you all can see. All good? Can you all see my screen? I will take the silence as a yes. Okay, so I will start my presentation. I'll start my presentation by acknowledging the traditional owners of the land I am on today, which is the Gadigal people of the Eora Nation, and pay my respects to the elders past, present, and emerging. I would also like to extend the respect to any Aboriginal and Torres Strait Islander people joining us in today's webinar. First of all, let's go into the most culturally and linguistically diverse countries of the world, which is Australia. The census collects a range of information that allows us to measure Australia's cultural and ethnic diversity. According to Australian Bureau of Statistics, which is also known as ABS, approximately 28% of the Australian population were born overseas, 22% of the people living in Australia spoke a language other than English at home, and approximately 51% of the Australian population were either born overseas or had parents who were born overseas. How did the migration actually started in Australia? So migration started increasing in Australia after the World War II and also in the 1970s and 80s. From the late 1970s, there was a significant increase in migration from the Asian countries, including China, India, and Philippines. Until late 1990s, there was a term which was used to describe the culturally diverse population, which is called which used to be known as non-English speaking background, or NESB. That was used to define or to refer to the people from multicultural communities. In the late 1990s, this term was not considered appropriate as a general purpose indicator for the diverse communities, as it was oversimplifying and it failed to capture the nuances of the culturally diverse population. So, at a meeting of Council of Ministers of Immigration and Multicultural Affairs in May 1999, Commonwealth and state ministers noted that there is a problem associated with the use of the term NESB or NESB. And they all agreed that this term or this acronym should be dropped from all the official communications. So in 1999, a pilot study was conducted, which was known as Cultural and Language Indicators Pilot Study, or CLIP. And it was conducted and to propose a standard of set of variables to measure cultural and language diversity in Australia in all the administrative and service provision settings. This data collection test involved over 5,000 clients who used the services provided by a range of local, state, and territory and Commonwealth government agencies. So this is a large sample size, and this large sample size allowed for a broad representation of the community in terms of response rates. So in 1999, CLIP study outcomes and some supplementary research and subsequent discussions were all used to refine and finalize a minimum core set of cultural and language indicators. And now, what are these indicators which came out of the study? Let's see in the next slide. These are called the ABS standards, and they basically have two groups. So one has core set standard, and there's a standard set. So the core set standard includes country of birth of person, main language spoken at home other than English, then proficiency in English. There's a fourth core set standard as well, which is called indigenous status, but I haven't mentioned it here because it's a different setting and it's a different group of population. So we're just focusing on the CALD indicators here. There's a standard set, which includes ancestry, which includes the core set standards, and additional to that, it includes ancestry, country of birth of father, country of birth of mother, first language spoken at home, languages spoken at home, main language spoken at home, religious affiliation, and year of arrival in Australia. So these are the standards which were provided or which were recommended by ABS, right? But are we including all of them in the health data sets in Australia right now? Let's see. So let's take a pause here before I dive into the detailed systematic review results. And let's look deeper into the indicators and the variables. But before that, let's practice a couple of activities, okay? So here I would like to engage in a quick activity just to get us talking about CALD variables and understanding of these variables which are collected in health data sets. So this is a table, and I would narrate an anonymous case to you, which is not real, it is made up. And I would ask you, how would you classify these cases based on the information I will provide you, based on the information which is being collected at the moment in health data sets, okay? So this is the first case. It is of a 20-year-old bisexual male who is born in Philippine family, who is born in Australia, and he speaks English, okay? But according to the variables which are collected, so he goes to a hospital and he provides the information on a form. And at the moment on a hospital form, the information which is being collected is country of birth and language spoken at home. So country of birth, he will write obviously Australia, and language spoken at home would be English. So if we were in a researcher working using this health data set, or we were surveillance officer using this health data set, we'd had only two CALD variables, country of birth, language spoken at home. How would you classify this case? You can write your answers in the chat box, or you can unmute yourself and just let us know how would you classify. If you were blindsided to the case history, you just knew these two things: born in Australia, spoken English. How would you classify? You would classify non-CALD or CALD or Australian born. How would you classify this case? Anyone? Don't be shy. Yep, Zihong, non-CALD. Yep, Australian. Absolutely right. So based on these two variables, we would actually classify this case as non-CALD, Anglo. Yes. Yes, we can't know until we know more information. That's true. But unfortunately, that there is no more information in health data sets. So yeah, we'll get into the systematic review results later, but you'll see that we don't have more information, and that's sad. So let's go into a hypothetical situation where you have free hand to collect more information or more variables. What other variables would you like to be collected to know more? Australian born English proficient. Absolutely, that's a very interesting way. So just give me examples of more variables which you would like to be collected in this health data set. Anything, be it ABS variable, be it non-ABS variable, anything. Ethnicity, yep, heritage, family of origin, identifying with any culture, ethnicity, absolutely. Other languages spoken, cultural identification, interesting. What a beautiful audience we have today. Absolutely. Ancestry, ethnicity, other languages spoken. Yep. So in the next example, I've just written country of birth of parents, but all these examples which you have mentioned in the chats are amazing. Absolutely. We need all these information, right? And then as soon as we have this little piece of information, which is country of birth of parents or ethnicity or other languages spoken at home, we would know it's a CALD case. So now you understand how much difference it makes to have the right indicators to be collected, and how much misclassification and misrepresentation can happen due to lack of appropriate variables, right? Thank you so much people who responded in the chat box. Were very, very interesting and amazing and actually appropriate indicators in the chat box. Similarly, let's go through this another hypothetical example again of a 37-year-old heterosexual woman born in Indonesia. She arrived in Australia in 2025. The variables currently collected are in a health data set are country of birth, Indonesia, year of arrival, 2015, language spoken at home, English, or maybe not, we don't know. I mean, how proficient is she in English, because she just arrived 10 years back. How would you classify this? Given these indicators, probably she will be classified as CALD, yeah? But we don't know other than that. We don't know anything about her migration journey. Is she a refugee or not? How did she arrive in Australia? We have no idea. Her struggles, her stigma, like her life story, we just don't know anything about her. And is there a language barrier? Because sometimes, to be honest, I'm from a CALD background, but I will just write English on a hospital form, sitting in a hospital setting, even though my preferred language would be something else. So yeah, we never know. Is English maybe not? So yeah, any other variables as you have mentioned in the chat box, like if we just ask on the form interpreter required, then maybe she'll come out and say, oh yeah, maybe I need an interpreter. So maybe we could have some idea, of a language barrier. And then yes, we will still be classifying both the cases in both the scenarios will be classified as CALD, but we will have no other information about her. Hence, we did the systematic review to understand what is happening in the health data sets in Australia. We do have ABS standards. We do have robust indicators which can be used to define CALD community. However, are we really collecting them in the health data sets? Let's find out. So we did this systematic review to see what CALD variables are being collected in research studies using health data sets and health research studies data. And do they align with ABS standards? And if they don't, what is the impact? So the inclusion criteria was pretty straightforward. We included the quantitative studies among the Australian population. And for the last 10 years, the last 10 years is 2023 because we started this systematic review last year in 2023. Hence it's a year backlog. And the exclusion criteria was qualitative studies were excluded, international studies and the non-English articles were excluded because it was a kind of a different setting if it was if it was a non-English article. Databases, we searched 3 electronic databases using UNSW Library Access, Medline, Embase, and Sinahil, and we also did a Gray literature search as well. These were the search terms, and these search terms were finalized after extensive stakeholder meetings with the CALD, the Health Equity Matter CALD affiliate group. And this was after discussion with them. After removal of the duplicates, we had around 2,251 articles for title and abstract review. And after full text review, we had 88 studies which were collected for data extraction, which used routinely collected data, and 72 articles which used individual study data. Results. So to present the results section and to make it easier and make sense and more engaging, I have divided the inconsistencies and the gaps we observed to be divided into 3 broad sections. The first section is about definitions used in health research studies to define multicultural communities. The second is about the indicators collected. And the third is about the terminology or the terms used to define the communities. So the first is, let's have a look at how multicultural communities were defined in health research studies. I know this is a busy slide. I'll just go through them one by one. So in this slide, I would like to discuss the various definitions being used in health research studies to define culturally diverse communities in Australia using the routinely collected data set. When we looked at the studies using routinely collected data, 48%, which is a little less than half of the studies, defined CALD as overseas born or categorized them as Australia versus overseas born. So in this categorization, someone who is not born in Australia was classified as CALD, which is not true. We all would agree here that this definition is the most inappropriate of all. According to this definition, someone who is born maybe in England or maybe in USA and is white and speaks English and has just arrived in Australia would be classified with someone who is maybe from Ukraine or is a refugee who has just arrived in Australia, which with limited English proficiency will be classified in the same group. So both these individuals who are so different will be classified in the same group, which we all can agree will be wrong. The other issue with this definition will arise is that people born in Australia but are from a culturally diverse background will always be grouped as Australian born. Hence, they will be underrepresenting the CALD communities in Australia. The second most used definition was actually 2 definitions, with 14% of studies used country of birth. However, they added another layer, which is categorizing the countries by excluding mainly English-speaking countries. So mainly English-speaking countries are New Zealand, Canada, USA, England, South Africa. They'll just exclude those and other countries as non-main English-speaking countries. And so people coming from non-main English-speaking countries are classified as CALD, and others are classified as people from main English-speaking countries. And there was this 14% who added another layer, that people from non-main English-speaking countries or who spoke language other than English were classified as CALD. So these were just layers which are a little better than overseas born, but still not perfect. So these categorizations have their own issues, which we'll be discussing in the later slides with language variable section. You can see here 9% just use the language spoken at home variable to define CALD population. So they were just asking people, do you speak English or not? And if they said no, we don't speak English, they were CALD. 3% use ethnicity to define CALD population for the study. Ethnicity variable had a very interesting way to be defined, to be honest, because they categorized. So in those studies, what happened was these studies were using routinely collected data sets, and routinely collected data sets collected country of birth. So they asked people, what country are you from? And in the analysis section, they divided them on, they just assumed ethnicity on the basis of country of birth. So if someone is saying, I was born in China, they would be like, okay, Asian ethnicity. So they just concluded the ethnicity based on the country of birth, which is very interesting. And other 3% use ethnic background or core background. So they ask people, what ethnic background are you from? And then based on the common nationality, they defined the CALD population. So we have grouped here ethnic background and CALD background together for analysis and presentation purposes, or else we'd have a lot of other categories here. Rest 8% used definitions like language spoken at home other than English, and interpreter was required or not, and other such little categories. And also based on ethnicity and religion, but it was, I think, only one article which used religion to define the CALD population. The next slide is about various definitions being used in the health research studies to define culturally diverse communities in Australia. So in data for research studies, we found that there were many more categories in the research studies, given there was more flexibility around collecting CALD variables in research studies, as they had more diverse CALD indicators to be collected. So more definition could be derived. When we looked at the studies using research data, 30% studies defined CALD on the basis of use of language or language spoken, and 28% defining the population as born overseas or born outside of Australia. And we have seen how this definition can be problematic. As you can see, there is much more variety in research study data in terms of collection of variables, and hence they can define the population in much more deeper levels. The only 3% of the studies defined CALD on the basis of country of birth of parents. So none of this research studies which are using routinely collected data defined on the basis of country of birth of parents. But I think 2 research studies defined country of birth of parents or self-reported cultural background. So they just, in the survey, they just asked, what is your cultural background? How do you identify yourself? So it was possible because the data was collected in a research study rather than data being used from a routinely collected data set, which has restricted variables collection. So yeah, do you have, Harrison is saying, let's take a pause for questions for a moment. So yeah, these are 2 slides which will have definitions. Do you have any questions or any comments at this point for the definition being used? I know this is problematic, but these are the observations we had. And this looks really chaotic and inconsistent. Have any comments or questions or any feedback or anything you think about that, or anything which you think, yes, this resonates? Yes, Daniel. Yes, go ahead.
Sorry about that. Can you hear me?
Yes, I can.
I find it interesting that when we're focusing on health, the focus in data sets and indicators is usually about language or culture or place of birth, which are all, and culture is important. I mean, there is all sorts of cultural beliefs about responses to illness and what health means and death and dying and childbirth. That's very important. But nowhere are we having the conversation, particularly with the increase in genomics medicine, about the actual biology of this as well. And ethnicity is poorly understood in Australia. And some people think it's aligned to culture. Other people think it's aligned to race, but we can't talk about race in Australia. But the actual genomics is important, and you're drawing all these conclusions just purely on cultural and linguistic and place of birth. So that's just a general observation, sorry.
Yeah, absolutely. I agree with you. And none of the studies were collecting, both research studies or routinely collected data collected ancestry variable. Instead of ancestry, they collected ethnicity variable, which we'll talk about in the variable inconsistencies in much more detail. But absolutely, I agree with you. And yeah, there is no clarity how to collect ethnicity variable as such. Instead of that, they're just collecting ancestry and the proxy is ethnicity. But what does it really mean? Any more comments? Nope, that's okay. We will go ahead, and then you'll have much more to discuss in the later slides. Variables used. So the second inconsistencies was about what variables are being used. So now let's have a look at the variables. So I have divided them into two slides. First slide, this slide is about the ABS indicators collected, and the second slide is non-ABS indicators which are collected. So as you can see, 85 studies which were using routinely collected data sets collected country of birth. 41 collected only country of birth, and rest collected country of birth in combination with other CALD variables. Main language spoken at home other than English was collected in 3 studies using routinely collected data sets, and 37 studies using research data set collected country of birth. Ancestry was not collected in any of the routinely collected data sets or in the research studies. However, an assumed proxy for ancestry, which is ethnicity, was collected, which we will discuss later. Multiple languages option was not available in any of the studies using research studies. Routinely collected data set, and 7 studies used information on religious affiliation. And I think these were all from the hospital data sets, because hospital forms do collect information on religious affiliation. So they were from that data set. Please note that these studies may have collected this information, but they are not necessarily these variables. They not necessarily used these definitions to define CALD population. So some studies were collecting more variables, but they did not use it to define that population for the study. Country of birth of parents was not collected in any of the health data sets, but it was collected in the research studies. More detailed tables in the next slide. So this slide is not ABS indicators, but they did collect residency status. So these 2 variables studies are from the tuberculosis notifications data. The TB data does collect information on residency status. So here we have grouped all ethnicity categories together and have discussed the ethnicity variations in the next slides. Ethnicity was defined using, as I said, assumed from collected country of birth in combination of religion, language. Now the language variable. Okay, but before going into that, let's engage into another activity. I'll just try to read one comment. I don't know what Daniel meant by we can't talk about race in Australia. If that's the case, let's start talking about it. Yep, that's true. But not talking about it hasn't served the purpose. That's true. And Justin has just replied. Mentioned early example, excluding overseas born from a country, South Africa. Yep. Absolutely. I agree with you, Jane. We had this biggest discussion because before we produced, we were working on the CALD enhanced report that how is South Africa really excluded as main English-speaking country, but that's the way ABS does it, and because their prerogative is that people who come from that country, from South Africa, are proficient in English, and that's sadly the way CALD population is being defined at the moment on the basis of language and on the basis of country of birth, which is something we have to work towards to change these prerogatives and to change this mentality that people who speak English, born in a main English-speaking country, can also identify as CALD. So yeah, thank you for bringing that up. I totally agree on that. So yeah, activity time. Here I will be, so this is an example of a 28-year-old male born in Australia in an Indian family who started speaking Hindi as a child, but spoke in English, in the school, or friends were speaking English. So as he grew, his first language kind of became, or his prominent language kind of became English, right? For obvious reasons. So here we'll see language variables, different language variables, how language is being collected in health data sets, different variations of language variables, and we'll see the potential response this man might have and the potential classification of this case. Okay, so don't be shy, just write in the chat box and I'll read it up for you. First variable is language spoken as a child. One of the study we had in the research studies did collect this information. They have the variable, which is very interesting. Language you spoke as a child, first spoke as a child. So what do you think will be the potential response for this case? First language they spoke as a child. Anyone? As a child, he spoke Hindi. Yes, so Hindi, and the classification would be CALD. If you just on the basis of language variable, okay, nothing else is provided, where he was born, where he grew up, what life history, nothing, just on the basis of language. If you say this will be CALD. Now, if you ask this person what is the preferred language, probably it will be English, because he grew up talking English with his friends. He grew up reading English. He grew up studying in English. His work language might be English if he's working, in Australia. The classification would be non-CALD. Then there's languages. So if in a study, people ask him languages spoken at home other than English, he'll probably provide, okay, other than English, yeah, probably I can write Hindi because I can talk in that language as well. CALD, okay? And then there's a language spoken at home. If there's another form where you ask language spoken at home, maybe English, maybe not. Maybe if his parents are like me, who are adamant that my child should be speaking in the language my background is from, maybe they will be talking in Hindi, but we never know. Sometimes people give up. Non-CALD. So this is just an interesting way to show how the classification changes just on the way this language variable is being collected. So it is really crucial how you ask this the variable. So it's like, yes, you are collecting the same variable, but is the information you are receiving the same? So that's the way, that's why we found so many inconsistencies the way language variable was collected. And hence, these were the questions which came up. So some studies asked main language spoken at home. Some studies asked language spoken at home. Some studies are language spoken at other than English. Some studies asked what was your first language, preferred language, primary language, all sorts of different variations. And you never know how people are actually understanding these questions. Sorry. So So what we found in language variable was that there was inconsistency in collection of the language variation. And this may be because ABS does suggest a lot of different standards and alternative questions to this standard. Language is a very tricky information to be accurately collected, to be able to offer information to a patient in a way they best understand. Responding to a language variable really depends on the setting and how the question is being asked. As we discussed, 12 studies collected information on language spoken at home. And in a hospital setting, if you would ask someone from CALD background, example me, like what is my language spoken at home, I would probably respond in English, because I know if I go in to the GP, I may not find someone who will be talking in Hindi. So I'll just probably write English. And I know there is no research to back this observation yet, but based on my discussion with my CALD colleagues and the stakeholders I've been working with, this observation was supported, that yes, they would probably write English, because they know the work language is English. You end up talking English more because your child is born here and he talks in English all the time. So you end up talking 80% of the time in English, even though your preferred language is something else, some other language. So yeah, this is a tricky area where maybe research needs to be done, where there's a gap there. Hence, we tend to respond different responses in different forms and different variations of language. Similarly, proficiency in English, that can be very important to know. However, it is a subjective response. An interpreter required can be used as a proxy here. Okay, so we are done with language variable, but let's dive into the ancestry variable. And as Daniel was saying, ancestry is a very crucial information to be collected, but really depends on the context and how you're using it, right? Let's look into this ancestry variable. Sorry, Daniel has said in healthcare and aged care settings, people with proficiency in English can revert to their original language for a number of reasons, including cognitive decline, absolutely, dementia, etc. Absolutely. I dream in Hindi, which is so funny because I've been in Australia for 11 years now, and I talk in English all the time, but I dream in Hindi. It's it's discussion for another day, probably. Ancestry variable. So ancestry and ethnicity have always been used interchangeably, and even in defining ethnicity, inconsistencies were observed. So the word ancestry is most commonly used in the literature to refer to genetic ancestry or combined, and when this is combined with the growing popularity of sites like ancestry.com, and as Daniel said, it may mean that people may respond, to the and interpret to this question as being about their genetic or biological ancestry, as opposed to the cultures or the traditions they currently identify with. Operationally, ancestry is defined as the ethnic origin or cultural groups which a person identifies as being his or her ancestry. The major advantage of ancestry variable is that it is able to measure an association with an ethnic origin and cultural groups, which cannot be measured by the questions of just country of birth or languages alone. ABS has a very robust coding called Australian Standard Classification of Cultural Ethnic Group, which provides detailed information of coding and categorizing the ethnic groups. And now actually you can record up to 4 options from 2026 census, which might be helpful to capture that more, ethnic diversity. But we are not even collecting in health data sets, we are not collecting ancestry variable at all. So these coding and these, this comes next or to the next level. We are not collecting ancestry at all. We are collecting ethnicity. So why not collect more information on this variable? In the next slide, I'm just giving an example of how we in the health data sets and health research studies are collecting ethnicity and how are we classifying them and how it is actually creating gaps. So this is just an example to show the ABS coding using classification of countries and classification of ethnic groups. So as I told you, some of the studies were collecting country of birth, and then they were classifying country of birth, classifying ethnicity on the basis of country of birth, right? So Australian Standard of Cultural Classification Ethnic Groups has 3 groups, which is broad groups, narrow groups, ethnic groups, okay? So in the broad groups, I'll just give an example of Southeast Asian group, which has, in the Southeast Asian, as you can see, according to the region of birth, they have 5 country of birth. But as you can see in the ethnicity coding, they have so many different ethnicities, which we have no idea about. So someone who's born in Thailand, what ethnicity are they from? We would never know. So studies which either collected country of birth and then they divided these using region of birth and they divided them into ethnicity using region of birth, or they collected ethnicity variables, but then used categories like Asian, Caucasian, African, which is actually region of birth groupings, not ethnicity groupings. So this collection and usage and this categorization of ethnicity variable is also very inconsistent and not in line with the codes. Hence, can not create reproducible results. And then we cannot, the linkage, which is like increasingly important these days among most of the administrative data sets, this cannot happen with CALD population because the results are just not consistent. And I understand these ethnicity coding are a bit hard to use, especially in a public health report. As I work for an annual surveillance report, we understand that in a data set where numbers are not large enough, then you can't narrow the numbers down to the ethnicity, example, Rohingya. So it might be, the numbers might be really small to be produced in a public report. I mean, it may create risk of identification. However, I just want to insist that there has to be a consistent way to define ethnicity and its usage is the first step. And then we can sort out how can we meaningfully produce meaningful results. Now, the third, as I spoke about the results section, the third was the terminology used. So what are the terms being used to address or identify the multicultural communities in Australia. But before that, do we have any comment on the variables or ethnicity variable or language variables, anything you want to reflect on, anything which you want to share, any experience which you might have had in, going through these slides? You might be like, oh yeah, I know this problem I've faced in my workspace, or anything which you want to say. Let's give time for people to type if they are typing. Yes, as Carlos is saying, speaking at home isn't always right for many reasons. Yep, that's true. That's true, because sometimes what the language you speak at home might not be the language you want to speak in a hospital, or might not be the language you. So actually, yeah, we can actually, I don't know, maybe just a suggestion which we have, maybe will come out. At home can be removed. Just what languages can you speak in, or what language you prefer to speak in. And I think we have to get out of this whole understanding of culturally and linguistically diverse people. Like, it's not just language and the place I'm born at defines my ethnicity. It's more than that. Okay, given the time, we don't have much time, so I'll just go. Oh, and Carlos is also saying it raises question on why the language questions comes up. Example, to provide effective care versus showing the diversity of members, etc. Absolutely. Why are we actually asking these questions is more important. Yep. Okay, let's move on to the terminology, which is amazing, which is another form of inconsistencies. So since Australia dropped the use of term NESB, which was non-English speaking background, in 1999, from all the official communications, CALD was most used term to define the population. However, overseas born was also used as well in the studies, and it was used interchangeably. With immigrant, migrants, 4% of the studies used multiple terms in the same studies to define the same population. So they were using CALD, they were using migrant, they were using immigrants in the same study to define the same set of participants, which was interesting to see. I understand that there is a shift in understanding of the term CALD as well, and now it is increasingly understood that this term might not be appropriate in identifying the racially marginalized and the sub-communities in CALD categorization, which might be facing stigma. So CALD was the original idea of introduction of CALD, culturally and linguistically diverse population. This term was replaced. It was introduced to replace the oversimplification caused by the term NESB. However, it might be time to reevaluate the term CALD as well, because under the whole CALD umbrella, there are other subgroups which might be more, stigmatized, which might be facing more, marginalization. And by just using CALD, we might be stigmatizing these populations more. So recommendation, and these are just recommendations on the basis of the observation we had, on the basis of the discussions with the all stakeholders we've had. Sorry. And these recommendations were that the ABS indicator, if all collected, are very well capable of identifying a very accurate CALD status of an individual. However, due to constraints of resources, and also as CALD population were not focus of health data sets, to be honest, until the last recent years, not all ABS CALD indicators are collected in the health studies. So by this review, we have derived a few observations. First of all, is collecting objective variables is recommended, like country of birth, year of arrival, country of birth of parents, which have very straightforward single answers. They are not let loose for the interpretation. So you can't have two country of birth. There will be one country of birth, and which can be proven as well if asked, which can be, if it's accurate or not, you can actually prove it. So collect objective variables. Second is consistent language variable. As we have seen through that activity, that their different questions the outcome can be different, the responses can be different for language variable. And we don't want that. So we want a consistent language variable. If we are collecting language variable, go for consistency, and we have to have a standard. ABS has provided several language standards to collect this information, but this may have created the inconsistent responses and information. So one suggestion we have is just adding other than English. So language spoken other than English, to just, capture that language diversity. This consistency created will also help in future linkage studies, as more systems are coming up where more and more linkage is possible among health data sets and other administrative data sets. Then other thing is adding country of birth of parents to routinely collected data sets. But I understand this might be tricky to add them to routinely collected data sets, as it is considered a bit discouraging at the physician level or at the health data collection level. If someone goes to a GP for getting maybe an HIV test, and then they get asked about their parents' country of birth, sometimes the GP might not be comfortable asking this question. So if it can be collected, great, but talking to GPs and CALD affiliate groups members, the general feeling was that this variable can be a hinder in rapport building between the patient and clinician, which is very crucial, especially in a stigmatized infection. But if it is in context, and if you can explain it before, it will be great to be collected. I'll just stop here, and then I'll give you an example of HIV notifications data. What do we collect in there? So in HIV is a notifiable disease in each state and territory in Australia, and these data are then forwarded to Kirby Institute for collation. The database where HIV notifications are stored is known as National HIV Registry, or NHR. The CALD variables which are collected in NHR are country of birth, language spoken at home, date of arrival and then we convert it into year of arrival in analysis. Other variables are gender, date of birth, postcode, the indigenous status, date of HIV diagnosis, etc. Now, if we look at the CALD variable, they are based on country of birth and they are based on language. But from this year, we have changed language indicator to language spoken at home other than English, so which might be helpful in capturing that language diversity a little bit more. I understand, and the whole team at Kirby understands that this is not enough. In classifying the diversity in the populations just on the basis of country of birth and language is not accurate, and we totally agree with it. But we all have to work towards the understanding and reaching the subgroups, which are often overlooked because there is no indicator to capture those subgroups. In the next slide, I do have some recommendations on the indicators for the routinely collected data sets and research studies. So let's have a look. So we've just created some set of questions for the routinely collected data sets. First is, what is your country of birth? What is your main language spoken at home other than English? Maybe we can remove at home after Daniel's comment. Then we can have interpreter required as a filter. So if someone says, oh, my language is any other language other than English, we can have, do you require an interpreter or not? What is your year of arrival, to know what the length of stay in Australia was? And then we can just ask, what ethnic or cultural background do you identify with? If explain the context beforehand, and also the coding should be in consistency with the ethnic coding, ABS ethnic coding. CALD population is in itself made of lots of subpopulation which have their own migration trajectory and their own struggles. These are the recommended set of questions which might be useful to identify CALD set of a person. So they are not really the bullet, the golden bullet which you needed, but some recommendations. For the research studies where we may have more room for asking a certain questions, as we might have a face-to-face interview or a survey. So the questions could be, What is your country of birth? What is your main language at home other than English? Again, interpreter required. Year of arrival. Then we could actually ask country of birth of parents here, which is a bit tricky at the routinely collected data set level. And then ethnicity. So if in a research study, questions like country of birth of parents can be asked depending on the context and if the context is explained earlier. And religious affiliation, if in context, it can be very useful as well. And the summary. So the CALD population is incredibly diverse, and we would agree, and has numerous subgroups. And each subgroup has its own unique migration history, taboos, stigma. While the ABS variables can be enough to determine the CALD status, it is crucial to delve deeper into the reasons behind data collection. Understanding the why helps to ensure that the data is used ethically and effectively to address the needs of these diverse communities. The least we could do is start by having a robust, consistent data collection system at the national and state level routinely collected data sets and research studies. So the data can be fairly representative and meaningfully interpreted by the community, and especially in an epidemiological setting or an infection which is already stigmatized. Having robust data collection is very important to be able to be fair, to have a fair representation of the population and to be able to reach the population which are already marginalized. Moreover, we must be mindful of the sensitivity surrounding individuals who are already stigmatized. This includes refugees, asylum seekers, stateless individuals. These groups often face additional layers of stigma and discrimination. For example, refugees and asylum seekers might not be counted in the routinely collected data sets, as no indicators identifying the population are collected in health data sets, in the routinely collected administrative data sets, and might not be adequately represented, leading to their needs being overlooked. Therefore, it is essential to approach data collection with the focus of inclusivity and respect for privacy. This means implementing measures to have meaningful, appropriate CALD data being collected, ensuring that the data is used to improve their circumstances rather than increase existing challenges and stigma. Thank you. And I can see comments in the chat box. What is the difference between cultural and ethnic background? So there is a difference, which is very minute, but yes, in this context, for this, most of the studies, it was the same. So it was a proxy for ancestry, and it means the ethnic or the cultural background you identify yourself with. Yes, Harrison, happy to take any other questions. Sorry, I'll just unshare my screen.
I think Daniel has a question.
Okay, so I know time is short. Thank you, Ella. I'm aware of your work and have been for some time. For those of you who don't know me, for my sins, I was at FECA, the Federation of Ethnic Communities Organisations of Australia, for 5 years. And in 2020, I wrote a paper on exactly the kind of issues that Ella's been talking about. I'm really heartened by observing a number of different research projects going around the whole country grappling with this issue. But I'm wondering if, and I did propose that in the paper, that there's time for a national summit on CALD data collection to bring researchers, practitioners, communities together. And I think that's important. As Ella suggested, we need to be really mindful of what we're doing here. So I think the first question is, why do we need this data? What's its purpose? There's a whole issue, no matter what data set subscribed, there's no actual compulsion to actually collect it. So it's really haphazard around the place. ABS originally suggested a minimum core data set from their standards, but no, it's not, as we know, as Ella's shown us, it's not done. So I think we need to part of this is the difficulty of mandating. I think it needs to be mandated mechanisms to collect the minimum data. And that's really clearly needed by the COVID experience. And I think that COVID gave great impetus to all this debate about the data. So there was no way of actually identifying cultural groups, ethnic groups, whatever, that were under-vaccinated, for example, or who are more marginally, who are more greatly affected. So there were things like, there were huge imbalance in fatalities from Middle Eastern people from Middle Eastern backgrounds. Is that culture? Is that language? Is that biology? No, it's not known. But it was only through really—
Sorry to interrupt, Daniel.
Sorry.
Just to say thank you. That's a really good point. I'm just really conscious of time. Are there any other questions from the group that we can talk through? But thank you, Daniel. Really appreciate that contribution. A national summit would be excellent, and I think he's very, very much needed. Sorry, just because we only have 4 minutes left, so I really want to just make sure that everyone gets a chance to have their moment with Ella as well. So thank you, Daniel. Did anyone else have any questions for Ella about the presentation today?
I would just like to add, Harrison, if we have time, on Daniel, what Daniel was saying regarding the summit. As Daniel and I have had so many conversations in the past year, and also with the CALD affiliate members, and I'm so thankful of all the members which gave me such great insight, and thank you for Health Equity Matters to making me a part of it. It was great discussion, and all of them, and Daniel did suggest that there were 8 different groups of researchers and community workers working in silos and working towards having a same goal, which was having a consistent framework for collection of data, called data. And if all of them can come together, and Daniel also suggested having a roundtable conference or something, would be so great. And I think FECA was working towards it last year, but I don't have any more information what happened to that plan. But yes, that would be a great way to start, because we do need some more robust discussion around. Now this systematic review has proven that there are inconsistencies. Where the inconsistencies actually lie, we have a very detailed data there. But how can we use it? How can we actually make it worthwhile, and how can we make the change happen? Because change is definitely needs to be happen. Definitely there has to be more variables added to the data collection, at least internally. Yes, in the administrative data sets, that would be great, but at least in the research settings, at least in the internal organization, we can make that change happen. And if that happens, maybe that can push and get that momentum to make changes at the government level as well. And that, yes, totally yes for the national summit, totally in for that. Any more questions or comments or reflection? And thank you so much for everyone who said thank you and appreciated the presentation.
Can you jump in and do the evaluation for me? I'll just
Thank you, Ella, and thank you everyone for joining us today. And yeah, we will be posting the evaluations. If you can evaluate the webinar, that'd be great. It'll help us improve this for the next financial year. So please, as well, if you want to see any other sort of topics in the next financial year, because we want to continue this conversation, please let us know as well, as we'd love to hear what you'd like to hear about, and try and get those in for our next financial year. Thank you, everyone.